I think the next two will each be 20, and I think 20 is probably a better time than 30 minutes. I think for little modules. And what do you think, Larry? An online course?
I mean, I think again, once it gets presented to a computer screen, I think it's just more stressful to watch it for a long.
All right, today's lecture is on erythrocyte or red blood cell disorders. So when we talk about red blood cell disorders, we basically have two different choices. We either have not enough red blood cells, which we call anemia, or we have too many red blood cells, which we call polycythemia. And the first one we're going to discuss is anemia or not enough red blood cells. So if you ever have a patient or someone that you see with anemia, the anemia is going to fall into one of three categories. Number one, you could have red blood cells that are too small. And a scientific word for that is microcytic. Microcytic anemia. The second issue we could have is red blood cells that are too big. And the word for that is megaloblastic anemia. And the third choice we have is red blood cells that are normal size. And again, the scientific word for that is normocytic. So first we're going to go back to too small. If you have a microcytic anemia where the red blood cells are too small, you essentially have three choices. The first choice is an iron deficiency anemia. And the cause here is that the person who's iron deficient does not have enough iron to make hemoglobin. If you don't make enough hemoglobin, hemoglobin is what fills the red blood cells, so they tend to be smaller in size. And they also, if you look at them closely, sometimes these red blood cells will be called hypochromatic, meaning they're less colored. And again, that's caused because there's not enough hemoglobin in them. So iron deficiency can come from blood loss, and it can also come from dietary iron deficiency. And in fact, the first cause here, blood loss, a common cause of microcytic anemia, and a common cause, you may know people with this, is, and the reason why anemia is more common in women than in men is because women will periodically, well, monthly, have a menstrual flow and a loss of blood from that. So women have a built-in loss of blood every month. And because of that, some of them, not most or all, will develop an iron deficiency anemia. And the second cause is dietary. And some people just don't have enough iron in their diets to produce the number of red blood cells that they need. So in those cases, they can be supplemented. And back to this blood loss. Also, another common cause of microcytic anemia due to blood loss actually can be cancer, and that would be when you see an older man or a postmenopausal woman who have what appears to be iron deficiency anemia. You have to ask yourself, how is this person losing blood, or could this person be losing blood? And it turns out that some types of colon cancer, when they're first starting along in the colon, they'll just bleed a little bit, and that blood will mix in with the stool in a manner that they won't even notice it. But it causes a chronic, slow, low-level loss of blood, which will first manifest itself as iron deficiency anemia, when in fact it reflects an underlying colon cancer. The second cause of microcytic anemia is thalassemia. Thalassemia is a genetic defect where you have decreased production of the globin chains. So if you remember from a previous lecture or from your reading, hemoglobin is composed of 4 globin chains, 2 alpha and 2 beta chains with heme molecule in the center. And thalassemia is a genetic defect seen predominantly in people of Mediterranean, Southeast Asian, and certain African populations where they have decreased production of the globin chain. And again, in the same fashion, the iron deficiency anemia causes decreased production of heme, which results in less hemoglobin. Thalassemia causes decreased production of globin, which results in less hemoglobin, which results in smaller red blood cells. And then the final category of microcytic anemia is anemia of chronic disease. It turns out that some bacterial organisms need iron. And they need iron in order to reproduce and in order to cause infections and things like that. And one of the body's defense mechanisms against those particular bacterial organisms is to sequester the iron that it has in circulation. It pulls it out so that these microorganisms can't use it and can't cause a serious infection. The downside of this is that sometimes we'll have a chronic infection, a chronic process going on that has nothing to do with a bacterial infection. The body still sequesters that iron and holds it back to protect itself, but the end result is that then it doesn't have that iron available to produce heme and to produce red blood cells. So again, the 3 types of anemia. The first one we talk about is too small or microcytic, and the 3 types that you should know about and the 3 most common are iron deficiency anemia, which is by far the most common of microcytic anemia, thalassemia, which is decreased production of the globin chains and it's a genetic condition, and anemia of chronic disease. Second type of anemia we need to talk about is when the cells are too big or megaloblastic. So sometimes they'll have someone who does not have enough red blood cells, but the red blood cells they do have are too big. And there are 2 types. There are 2 conditions which will cause this megaloblastic anemia. First off, we have vitamin B12 deficiency. And vitamin B12 deficiency is seen in decreased absorption, where the body is unable to absorb the vitamin B12. And in fact, this condition is called pernicious anemia, if you've ever heard that. It's caused by antibodies to the parietal cells of the stomach. The parietal cells of the stomach produce something called intrinsic factor. Intrinsic factor in the stomach complexes with dietary vitamin B12 and enables it later on to be absorbed in the small bowel. And then vitamin B12 is used to produce in the production of DNA, and it goes back into the DNA cycle of the stem cells, and you're unable to produce enough of these red blood cells. But the ones you do produce will be big. So that's the macrocytic anemia. The other one is, the other issue you can have with vitamin B12 is dietary insufficiency or dietary lack. Now, frequently we see, in the United States, we'll see vitamin B12 deficiency in alcoholics, and because they're just drinking alcohol and not getting the nutrition they need. The other people that you might see vitamin B12 deficiency in is really strict vegetarians. Vitamin B12 is found almost exclusively in foods of animal origin. So a really strict vegetarian who does not take vitamin supplements could develop a vitamin B12 deficiency. The other one might be the elderly, sometimes elderly who live alone will get into poor dietary habits. The one that we may classically think of is the little old lady who lives on tea and toast or something like that. Just has a poor dietary intake and does not have a lot of food of animal origin in her diet, or his diet for that matter. But the elderly also are another group of people that will see vitamin B12 deficiency. The second cause of megaloblastic anemia is folate deficiency. So again, commonly also seen in alcoholics, and folic acid is present in a wide variety of foods, both of animal and vegetable origin. So it's not seen in vegetarians, and you don't need intrinsic factors to absorb it, so that's not a problem there. But folate deficiency is the second cause. Sometimes you can also see megaloblastic anemia from liver disease. But the two that you'll be responsible for are B12 and folate deficiency. Now finally, the third reason that we have anemia, or the third category of anemia would be a normocytic anemia, or where the red blood cells are of normal size. And there are different functions for that. There are different causes of that. In fact, the list is longest for the normocytic anemias. But the ones that we'll talk about here are acute hemorrhage, meaning that the person that we're talking about with the anemia here has just barely bled. Say they've been in a car accident, they've bled out several units of blood, they're rushed to the hospital. The first thing they do on the way to the hospital is they hang normal saline or some other type of IV fluid to try to keep their blood volume up, to keep them from going into shock, and so they have blood going out and essentially salt water coming in. That the salt water or the saline dilutes out the blood that they have. So the red blood cells are going to be the same size they've always been, but there will be less of them. And so that will give them a normocytic anemia. You can have a stem cell dysfunction. A classic example of that is aplastic anemia. We have talked about that in a previous lecture, but aplastic anemia means that most of the stem cells have been wiped out. There may be just a few or even none left, but if there are a few left, they're producing cells, but the cells they are producing are normal size and normal appearance. There just aren't very many of them. And also there's what we call myelodysplastic syndromes. And the myelodysplastic syndromes are caused when the stem cells are just not functioning well. They're diseased, they're not producing it the way they should be. The ones they do produce are normal size, but there are not as many of them as there should be. Malignancies will give you a normoblastic anemia, or normocytic anemia. Hemolysis. So examples of those are mechanical. For instance, a classic example, a mechanical hemolysis is when you have a heart valve, an artificial heart valve that's made out of metal or something else. And so it's clicking and it's working, opening and closing the way it's supposed to be. But every time it closes, you got these metal edges coming together in the flow of the blood, and they're clicking back and forth and smashing red blood cells to pieces every time they do. So they will destroy those red blood cells and give you a normocytic anemia. Infection, where an infectious agent of whatever type is present and is destroying red blood cells, but the ones that are left are normal in size. You'll have an autoimmune anemia, and that will be where the body makes antibodies to its own red blood cells and is destroying its own red blood cells, but those that it has are normal size. And then finally, there's anemia called splenic sequestration. Now, at times, for various reasons, the spleen swells up. And as we've talked about in a previous lecture, the spleen is a reservoir for red blood cells. If you have trauma, it can squeeze down and release red blood cells into the bloodstream, sort of like giving you a blood transfusion. But the converse is also true. It can swell up and take red blood cells out of the bloodstream. So you can at times have splenic sequestration, which takes red blood cells out of circulation. So just a quick review here, what we talked about. Anemia, there are two different things we're going to talk about, anemia. And anemias have, there are three big categories. Number one, too small. And that is caused by decreased production of hemoglobin, usually either caused by iron deficiency, thalassemia, or anemia of chronic disease. They can be too big, where you're lacking either vitamin B12 or folate. Or finally, red blood cells are the normal size, and this is really the most complex and largest category, but the ones that you need to be responsible for are acute hemorrhage or acute blood loss, stem cell problems where they're not producing enough red blood cells, hemolysis where the red blood cells are being produced but they're being destroyed for whatever reason, and splenic sequestration where you really still have all the red blood cells, they're just stuck in your spleen and they're not getting out to circulate where they need to be. So those are the causes of anemia that you need to be responsible for, and we'll go ahead and move on. The final red blood cell issue that we're going to talk about is polycythemia, and that's where you have too much. So polycythemia, we categorize that as either primary or secondary. Oops. Okay, and polycythemia, the primary cause is polycythemia vera. Oops. You can read about this in your text, but polycythemia vera is a neoplastic disorder or a myeloproliferative disorder where the stem cells in the bone marrow are producing too many red blood cells. They should be producing more, or they should be producing less, but they're producing more. So normally the body will produce red blood cells so that a person will have a hematocrit of a little under 50%, meaning what that means is that when you take this is a test tube here of blood, and if you spin it down, the hematocrit would be the red blood cells would be down here. And if you measure this is a little, in a normal person, is a little less than 50%. So let's say about 45%. So a hematocrit of 45 in most people would be considered about normal. And then the other 55% is composed of the plasma portion of the blood or the liquid portion of the blood. So in someone with polycythemia vera, they may have a hematocrit of 60%, even 65%. So markedly elevated. And the reason that that's a problem is that if you don't have enough of the liquid portion of the blood doesn't flow as well, and it doesn't flow through the capillaries as well. So these people with polycythemia vera are prone to have strokes or heart attacks or thrombotic events where the blood is no longer able to flow, and everything beyond that point where it's not able to flow dies because it's not able to get oxygen. So in people who have polycythemia vera, the way we cure them is we take blood off them. We bleed them, just like they used to do in the old days. In this case, it works, though. So we'll have people come into our laboratory, for instance, and our laboratory techs will take off a full unit of blood every 2 weeks until their hematocrit drops down into a normal range. Then they have to keep being watched because their stem cells are still functioning. They're still producing red blood cells, and they will go produce more. Secondary polycythemia is caused by, well, the most common cause is hypoxia. So if you don't have enough oxygen, your bone marrow senses that and produces more red blood cells so that it can carry more oxygen to your tissues. So where you might see this would be people who have chronic lung disease, so they're not able to get enough oxygen into their lungs, so that they will compensate by producing more red blood cells. The other place that we see it sometimes is people who live on, say, the Bolivian Altiplano, where they live at 11 or 12, even 12,000 feet. So they're really, really at a low oxygen tension, and they compensate by producing more red blood cells, and they'll develop polycythemia. And even here in Laramie, although we don't reach the polycythemic state, the hematocrits tend to be a little bit higher, and we have to compensate for that and realize that. Another common cause of secondary polycythemia is blood doping. And we see that in sort of high-tier athletes who will either take erythropoietin, which causes the bone marrow to produce more red blood cells, or they'll actually give themselves blood transfusions to increase their blood count. And this gives them a competitive advantage when they're running against people who have a lower hematocrit, because they're able to carry more oxygen and deliver more oxygen to their tissues, and hence able to generate more of an athletic effort. So it's a real problem in professional and high-level sports today. But the converse side of that is that these athletes that are doing the blood doping run a greatly increased risk of having a stroke or a heart attack or another serious effect, which will bring a very quick end to their athletic careers. So we've talked about disorders of erythrocytes. The two, again, just to summarize, the two different disorders we have are either not enough, which is anemia, too much, which is polycythemia. And then we talked about the different types of anemia: microcytic, megaloblastic, and normocytic. And polycythemia, which is too many red blood cells. We split that into primary polycythemia and secondary polycythemia. And thank you for your attention today.